I rise in strong opposition today to A4052, which removes long-standing patient protections by eliminating physician oversight of certain advanced practice nurses. This bill removes the requirement for a collaborative agreement or a joint protocol, which has long been a pillar of the team-based approach to medical care, which prioritizes the safety and appropriateness of medical care for our citizens. And this is not about diminishing the role or scope of practice of nurses or advanced practice nurses. APNs are highly valued members of the healthcare team. They play an essential role in caring for patients across our state. I work alongside them every day, and I have tremendous respect for them. This question is about maintaining standards that protect patient safety in New Jersey. The joint protocol is not a formality, it is a safeguard. It ensures that when medical diagnoses and treatments become complex, there's a structure for collaboration and oversight so that the patients are the beneficiaries of the highest quality of care. This bill removes that safeguard. It allows independent prescribing, independent diagnosis, and independent treatment decisions without any requirement for physician involvement in primary care and behavioral health, which leaves an enormous swath of medical care in New Jersey without protective oversight. In many cases, it places APNs and physicians on effectively the same legal and clinical footing, despite very different levels of clinical training, and that difference matters. Physicians typically complete 4 years of college, 4 years of medical school, and between 3 to 7 years of residency training, accumulating roughly anywhere from 12,000 to 20,000 hours of directly supervised clinical experience before they can ever take care of a patient independently. And that training is structured, rigorous, and specifically designed to prepare physicians to manage complex and high-risk cases. Advanced practice nurses typically complete just a fraction of those clinical hours, often in the range of less than 1,000 hours. And these are not small differences. They're fundamental differences in training, in clinical exposure, and in preparation for independent medical decision-making. The central issue here is patient safety. Medicine is not just about routine medical care. It's about recognizing when something is not routine, when a subtle symptom signals a serious condition, when a treatment choice carries hidden risks, when a patient's condition can deteriorate quickly. Oversight and collaboration are not barriers to care. In fact, they are protections. They are part of a system designed to reduce errors, improve outcomes, and ensure that patients receive the highest level of care in a timely manner. Supporters of this bill often argue that independent APN practice is just as safe as physician-led care. Much of that argument relies on the idea that during the COVID-19 pandemic, when a temporary executive order relaxed these requirements during a crisis, there was no documented increase in harm. But an absence of reported harm is not the same as evidence of safety. We do not have a comprehensive, standardized system that captures all the ways patients can be harmed in clinical settings. These include misdiagnoses, delayed treatment, inappropriate prescribing, over-consulting, and unnecessary testing. And these outcomes often go unreported or are never formally attributed to a specific provider. So we should not base permanent policy decisions on incomplete data and assumptions based on intuition. We also need to be clear about what happened during the COVID pandemic. The executive order that temporarily relaxed oversight requirements was issued during an unprecedented public health emergency. It was intended to give physicians flexibility while they were managing an overwhelming number of critically ill patients. It was never intended to permanently restructure nursing scope of practice and reduce safety standards for healthcare delivery in New Jersey. And very importantly, collaboration did not disappear during that time. In fact, in many instances, it increased. Hospital intensive care units, emergency rooms, and operating rooms continued to rely on physician-led teams, and APNs and physicians worked together more closely than ever before. To take that temporary emergency measure and use it as justification for permanent policy change is simply not supported by the reality of what occurred across the state. There's also a claim that this bill will reduce the cost of care, but the available evidence suggests the opposite. In fact, studies have shown that when care is delivered without physician involvement, there are higher rates of diagnostic imaging, more diagnostic testing, more consultations, longer emergency department stays, worse outcomes, and increased rates of hospitalization and readmissions. especially with more complex patients. All of these factors drive costs up. So instead of reducing healthcare spending, we're creating a system that costs more while delivering less efficient and less safe care. Now, regarding access to care, access to quality and affordable care is often a real issue. There are communities in our state that need more primary care and more mental health services, and that is not in dispute. But removing physician oversight protections does not guarantee that providers will go where they are most needed. In fact, we have evidence that the opposite has occurred while the executive order was in effect from 2020 until it was recently rescinded and then extended. Instead of an increase in access to primary and behavioral care to those who need it most in underserved areas, we saw a significant increase in cash-based aesthetic and elective practices, often in settings that offer unserious and potentially dangerous medical care. In fact, the medical spa industry has exploded in New Jersey, with 60% of New Jersey medical spas having opened since the COVID waiver was put into place. Clearly, this does not address the problem of access to necessary care. In fact, it likely makes it worse due to APN migration to more lucrative practices that do not provide necessary services in underserved areas. If our goal is to improve access, then we should pursue policies that target the actual causes of access problems, not policies that remove safety guardrails and let's hope that the market fills the gaps. This is not a turf battle, it's a question of standards. Do we maintain a system that flourishes with collaboration, oversight, and patient safety, or do we now move to one that removes those protections without clear evidence that doing so will improve outcomes? Access and safety are not competing values. Our constituents deserve both. Studies show that the vast majority of patients in New Jersey want a physician to be a part of their care. So I would ask each one of you to consider what medical care protections you would choose for your families and for yourself and legislate accordingly. For these reasons, among others, I strongly urge all my colleagues here to vote no to preserve safe medical care in New Jersey. Thank you, Mr. Speaker.